Hi everyone, welcome to ResearchMD.com. Another great presentation. We're going to teach you everything about Cushing Syndrome. Okay, that's our topic today. Before we go into the topic, this is going to be a brief introduction. My name is Dr. Pramil Cheriyath. I'm a program director, internal medicine residency, transitional residency, and I'm an associate professor of medicine to a large medical school in the United States. We've been doing a series of lectures on endocrinology. Please make sure you watch those lectures. It will be very, very important to you. Okay, so today let's go and let's talk. Okay, we don't have any time to waste. Cushing syndrome. First of all, we need to look at the definition. I'm going to read the definition. Clinical condition resulting from chronic exposure to excessive level of glucocorticoids. Okay, when you talk about glucocorticoid, let's go back and visit the adrenal gland, right? Adrenal gland got three parts, right? Zona glomerulosa, zona fasciculata, zona reticularis. So where is this coming from? Zona fasciculata and reticularis. Okay, zona glomeruli is aldosterone. Just remember that. So we got glucocorticoid. When you talk about glucocorticoid, just remember we mainly be talking about cortisol. Okay, now how does the cortisol is produced? You got, it's kind of breaking down from cholesterol with the different enzymes. So you got cholesterol, pregnenolone, progesterone, and then you got 17-hydroxyprogesterone, corticosterone, and then finally you get the cortisol. Okay, so we need to know that. Just remember the how it's produced also. Now next thing we need to differentiate the two terms we need to know. There is something called the Cushing Syndrome and Cushing disease. Okay, so our topic is Cushing Syndrome. Okay, so when you talk about Cushing syndrome, that means you got excess glucocorticoids coming from any source. Okay, it could be anywhere it's coming from. But when we talk about Cushing disease, this is something coming from due to excess ACTH from the pituitary gland, is in the brain. Okay, remember the difference between Cushing syndrome and Cushing disease. Cushing syndrome is like glucocorticoids from anywhere. The other one mainly ACTH, like pituitary relationship. Remember that. Now, let's look at some numbers. Prevalence, where is it more common? Females, right? And then at least 3 to 5 more times likely, especially if you're reproductive age, high risk. And then you got 40 cases per million. That is, it is rare. Remember that. Now, when I look at the causes, the first thing we always have to roll out the exogenous code. People are taking some steroids, exogenous or iatrogenic. That is the most common. That's what you need to roll it out. Don't forget it. Before you do anything, you have to roll that out. So that is the most common cause. Now let's look at the other causes, which is the endogenous causes in the body, right? Primary hypercortisolism, that is ACTH dependent, that's around like 10% of them, okay? Now what are the causes? You get adrenal adenoma, adrenal cancer, macronodular adrenal hyperplasia, all of this come under the primary hypercortisolism, which constitute around 10%. Now secondary hypercortisolism, we have to think about, the main thing is the Cushing disease, pituitary dependent ACTH, right? So it causes the pituitary adenoma, 75%, my friend. So always kind of think about 75% coming from the pituitary adenoma. Okay, so pituitary dependent, ACTH causing the problem. Then there is like 15% is ectopic ACTH. It could be anywhere in the body, but trying to act like, to function, produce ectopic ACTH. So what are the cancer? What kind of cancer you can have? Small cell cancer, pancreatic cancer, renal cell, you have bronchial carcinoma, pheochromocytoma, all of this can do it, okay? Now, let's look at, now we just kind of looked at it. Now, how do we investigate it? This is the most important step you need to know. Okay, it's got like series of steps you have to do, but we're going to walk you through each step, my friends. Okay, so first thing is always, what did I say the first thing to do? Always rule out the exogenous causes. If you're suspicion for Cushing syndrome, always do that. Okay, so number one, that is the most common, exogenous or iatrogenic. Make sure your patient is not taking steroids, not giving steroid, take it out. And then if you roll that out, and then you look at your suspicion is low or high. Okay, there's 3 tests you have to think about it. Late night salivary cortisol, 24-hour urinary free cortisol, and you got overnight 1 milligram dexamethasone suppression test, which is actually called DST. Okay, so what do you do is, if it's low suspicion, you can do 1 test. If it is like abnormal, then you repeat 2 of the screening tests again to confirm it. Let's say your suspicion is high or like intermediate or high, you do like 2, at least 2 or 3 tests in a year. You can pick any 2. Okay, if it is abnormal, you repeat again, 2 screening tests again. So make sure that you know. you have to repeat the test. Once you repeat it and then the test come back positive, pretty much we know this is Cushing syndrome. What does that tell us? Only thing it's going to tell us is like it's Cushing syndrome. There is like a lot of glucocorticoids coming in, but we don't know where is it coming from, right? So we need like further investigation to find out where it's coming from. So we have come with our diagnosis, Cushing syndrome. Next thing is everybody know we need to measure the ACTH. Let's say the ACTH you measure and the ACTH is low, then we know it's an ACTH independent tumor, and then you have to look at the adrenal tumor or any other exogenous source. You have to look at that time. Okay, remember that. Now let's say you measure ACTH and it's high. What's going to happen? It's an ACTH dependent tumor. And then you have to know then you have to do like 2 more tests to confirm, to find out where exactly coming from. You can do either high dose dexamethasone suppression test, or you can do Crh stimulation test. Any of this can be done. Let's look at the first one. You got the high dose dexamethasone suppression test. If there is no suppression, that means it's an ectopic ACTH. And then you have to do a CT test in abdomen and pelvis to find out where's the ACTH is coming from. Look at the ectopic source. Now, if there is suppression of the ACTH, then we know if there is, when you give high dexamethasone suppression test, it's an adequate suppression of cortisol actually, then you know it's like Cushing disease. That means like pituitary related, right? Then you do the brain MRI. Now, let's look at the Crh stimulation test. You do high ACTH, you measure, you do Crh stimulation test, okay? Then you had like high ACTH and high cortisol, then you know it's a Cushing disease, kind of like pituitary. Now, no ACTH or non-cortisol, you think about ectopic ACTH. And then once you know the ectopic ACTH, what do you have to do? You have to find out where this ectopic ACTH is sitting. You do like an abdominal CT, chest and all that to find the things, okay? So you have to differentiate in when do you do the MRI, when you go for CT of the abdomen and pelvis. Now let's look at the clinical features, my friends. Okay, everybody know pretty much, I think everybody remember the striae, the abdominal striae, the skin findings, so we'll start with that. You have thinning, fragility, striae, delayed wound healing, all of this kind of relate to the skin. The next thing, let's go to the brain. What's happening in the brain? Always remember, psychosis. Remember, we can have steroid-induced psychosis, so very common, right? Same thing, I'll start with the psychosis, depression, anxiety, cognitive disability, and because of the brain, it can cause like decreased libido also. Okay, now let's look at the eye. There should be some cataract formation. Now, if you look at headache, you can have in the headache also, and if you look at you got the buffalo hump on the shoulder, and then you got moon face, if you look at the face, and you look at the cardiovascular, it can cause like high blood pressure, and then when you look at the stomach, there's peptic ulcer disease in these people, and then muscular atrophy and weakness, if you look at muscles. And then let's look at the female and male sexual function. In the female, irregular periods, male, it causes erectile dysfunction. So when a patient, you're thinking about erectile dysfunction, it's good to do all these investigations, okay? And then there's going to be definitely insulin resistant, increased chance of infection because the blood sugar is like really high in these people. Now, there's also what happened to the bone. There's like increased fracture. They can have like, bone formation. Bone is going to be fractured. So always like, we have to be very careful about that, okay? You need DEXA scan like frequently and check on these people. Now, how do you treat it? The first line is always surgery. We already told you, right? It's a pituitary adenoma, 75% of the cases, my friend. So you go for surgery, first line, and pharmacology, second line, adjunctive therapy. You can use an enzyme inhibitors, Cortisol or metyrapone, and glucocorticoid antagonist, which is actually mifepristone, okay? Now, when you talk about, there's another like second line, you got pituitary target drugs, dopamine agonists like cabergoline, and then somatostatin analogs, you called pasiritotide. Okay, those are the things. So let's go back and once we make sure this is second line only in Cushing disease. That's very important to remember. Only second line in Cushing disease, okay? And the other thing is the first line always, remember like surgery. If I cannot remember anything but remember surgery. Now I'm going to take a step back, look at our beautiful whiteboard again, and summarize our findings like one more time. So let's summarize, my friend, what's going on. Everybody know the first thing is like there is excessive levels of glucocorticoids, okay? And then differentiate between Cushing disease and Cushing syndrome. When you talk about Cushing syndrome, you talk in the whole picture. A lot of glucocorticoids from any source. When you talk about Cushing disease, is pretty much pituitary, okay? And then you talk about this females much more. And then exogenous iatrogenic is the most common. So make sure you rule that out. And then you got primary hypercortisolism, you got secondary hypercortisolism. Always think pituitary ACTH or Cushing disease like 75%. One more time, 75% is like pituitary adenoma, or like you can say like pituitary ACH or Cushing disease, we can say that, okay? Now, the ectopic ACTH, make sure like the cancer, like it could be pancreatic cancer, small cell cancer of the lung, bronchial carcinoma, and pheochromocytoma, the most common cancers associated with it. Now, let's look at the diagnosis. What's the first thing you have to do is make sure you rule out the patient is not taking any steroid, rule out all the exogenous causes of this steroid, okay? And then you look at your suspicion. If it is low, then you put intermediate or high, and look at the 3 tests right here. What are the 3 tests? Late night salivary cortisol level, you got 24-hour urine-free cortisol, and then you do the overnight 1 milligram or low dose DST, dexamethasone suppression test. You do this, you come back abnormal, you repeat it again. You do again 1 or 2 tests. Don't pick only 1, you have to pick like 2, minimum 2 tests, remember that. And if it is high, then you got your diagnosis as Cushing syndrome. Okay, once we have the diagnosis of Cushing syndrome, we need to differentiate where is this problem is coming from, right? We need to know if it is Cushing disease or something else kind of going on. So first thing you always check is ACTH. So what happened? If the ACTH is low, we can always say ACTH independent, because what happens is like you get adrenal tumor producing a lot of cortisol, and then that's going back and inhibiting there's negative feedback. So there will be less ACTH. Remember that, okay? So ACTH is low. You can say it's an ACTH independent adrenal tumor, or it could be an exogenous source. Let's say you measure the ACTH, it's high, then you have to differentiate, then you know it's an ACTH dependent. Then you have to differentiate either it's Cushing disease, which is coming from like a pituitary, or it's an ectopic, right? So there's 2 tests you can do. The 2 tests is given. One is high dose dexamethasone suppression. High dose is right here, okay? And here you can do Crh Stimulation Test. When you talk about high dose dexamethasone, you measure the cortisol, there will not be any suppression, because this is an ectopic. They don't have the receptor. So what's going to happen is like this. Then you can say it's an ectopic ACTH, okay? That means then you have to do other investigation to find out where's the source. It could be pancreas, lung, or whatever. So you do a CT, chest, abdomen, and pelvis. Let's say there is like cortisol is suppressed. Then you know it's coming from this the pituitary, like Cushing disease. And then that's when you have to investigate the brain. You go over the MRI. So you have to differentiate. When do you do the MRI? When you do the CT, chest, and abdomen, pelvis. If it is ectopic, you're always kind of trying to find out. So you do high dose dexamethasone suppression test, and if it is no suppression, then you know it's like an ectopic, okay? Remember that. And if there is adequate suppression, it's Cushing disease. Same thing with the Crh stimulating test. You do you give like Crh stimulation, there's high ACTH and cortisol, then you know it's like a Cushing disease or pituitary. You go for MRI, and there's no increased ACTH or cortisol, then you know it is pretty much an ectopic tumor, right? Ectopic tumor is kind of producing, and when you have to do abdomen, CT, chest, and pelvis, remember that, okay? Just review this thing one more time, and then we talk about all these features. Pretty much everybody know what moon phase, buffalo hump, striae. Remember the glucose metabolism affected. There's glucose insulin resistant, and increased risk of infection, bone fracture, irregular menses, and muscular atrophy and weakness. And always remember the number one also, if you cannot remember, psychosis. Remember, we made a presentation earlier. Just go and make sure you review it. Steroid-induced psychosis, my friend. And the treatment always picks surgery is the first line, and then you got second line, you got adjunctive enzyme inhibitors, ketoconazole, meteropone, glucocorticoid antagonist, mifepristone, and the second line in Cushing disease is what you have, pituitary pituitary target drugs like dopamine agonist, carvedilol, somatostatin analog called pasireotide. Okay, thank you so much for watching. Please make sure you review this again. It's a very important topic and a difficult topic also. All these hormones, where does it work? So make sure you review it again. Please study hard. Thank you so much.